Hi, good afternoon. I am Bella. I am the Patient and Advocacy Coordinator, and I am leading this webinar in place of Ellen Hostetler, who is on a flight right now. So you normally see Ellen's face. Today you're going to have me. I'm just going to go over a few housekeeping slides before we get started. Hopefully everybody can see the slides and the chat. Let's see. So, just some background, remind you guys who we are, John Ritter Foundation for Aortic Health. We are a registered nonprofit that was established in 2003 by Amy Yazbek after the sudden passing of her husband, John Ritter, from an aortic dissection. We host virtual and in-person patient events, provide resources for patients and families worldwide, and we participate in events like the New York City Marathon. This is an example of the type of support that we provide. Peer support, we build community, we fund research, we provide caregiver support, educate patients and professionals, and try our best to help everybody impacted by aortic disease. Today's webinar is decision making around elective aortic surgery, choosing a surgeon, second opinions, and shared decision making. Please use the Q&A to submit any questions that you have. We'll have a Q&A following the presentation. We have also received some questions ahead of time. If we don't get to your questions today, please feel free to email them to us and we can get back to you. We will also be having, I know some questions have to do with exercise. We'll be having Dr. Siddharth Prakash speak during Aortic Dissection Awareness Week next month, which will be between September 14th and 20th. And the webinar is being recorded, so you all can view the recording on our YouTube page and it will be available to share afterwards. Please introduce yourself in chat, tell us where you're from, where you're joining us from, connect with others, and thank you for being here with us today. And as always, a disclaimer, the information that's given throughout this webinar is not to be intended for medical advice. Please consult your doctors for any questions. We are providing information to help guide you to the best resources and care for you. And here is our email and our support page, which we'll be also sharing throughout the chat, throughout the presentation, if you all have questions that don't necessarily pertain to today's topic, or if we don't get to your questions today. And with that, we will introduce Dr. Takayama. All right, Christina?
Yes, thank you so much, Bella. I appreciate it. So just wanted to take the time to introduce Dr. Takayama. Dr. Takayama is the Chief of Adult Cardiac Surgery at New York Presbyterian Columbia Irving University Medical Center. He has more than 20 years of experience in treating patients with heart and vascular problems. As the director of the aortic surgery program and the co-director of the aortic center, as well as the hypertrophic cardiomyopathy center and Marfan Clinic at NYP Columbia, Dr. Takayama has contributed to the care of over 4,000 patients by performing a variety of aortic and cardiac surgical procedures, approximately 300 to 350 operations per year. He's internationally recognized for his work on complex aortic surgery, minimally invasive aortic surgery, valve-sparing aortic root replacement, aortic valve replacement, aortic arch, and thoracic abdominal aneurysm repair, as well as hybrid aortic surgery and myectomy for obstructive hypertrophic cardiomyopathy and heart failure surgery. He is a leader in outcome research in aortic disease and heart failure and consistently publishes many manuscripts in peer-reviewed journals. Dr. Takayama, take it away.
Excellent. And hello, everybody. Thanks for inviting us to this exciting webinar series. I'm here with my close team members, Dr. Virendra Patel. Some of you probably know his name. He sits in the board of the John Ritter Foundation. And also, he's the chief of our vascular surgery. And Annie Yu, our nurse, chief nurse practitioner, she is the main person who is the main interface with our patients in our aortic center. So three of us can take any kinds of questions that you may have. And to start the discussion, I prepared some slides. So I would like to start this webinar with these slide presentations. Here are my disclosures. First, I thought, regardless of the title, I thought it's a good idea to start with this slide. This is the text message exchange with one of our referrals recently. And more frequently, I've been asked this question: do you usually operate at 5.5 centimeters or now 5 centimeters because of the new guideline? In today's talk, I try to answer this question, and it is not as simple as it sounds. First, I would like to just go over certain facts and reiterate the goals of managing patients with aortic aneurysms. As you all know, aortic aneurysm typically does not cause any symptoms, which is important. And one day, though, it ruptures or dissects, and you go into a very difficult situation. And that's what this John Ritter Foundation is about. These aortic events have an extremely high mortality rate, again, dissections and ruptures. Approximately 43 to 47,000 of deaths in the US are due to thoracic aortic aneurysms, and it is 15th or so of leading cause of death. With that, the goal of aortic aneurysm management for us is clearly to prevent aortic events. And we have another goal, that is to bring back normal life to our patients. In any event, we should go to the guideline to find the answer to our question. Again, do we operate at 5.5 or 5? This is the summary slide by the 2022 ACCHA Guideline Committee. And as many of you are aware, the guideline was updated a few years ago. It looks very, very complicated, so I'll make it simple. Instead of following this complicated chart or reading the guidelines line by line, let me provide some context to understand the rationale behind the decision making, especially the size. First, the definition of aneurysm. Combining databases with a large sample size, the risk of aortic dissection, and as you see in this chart, was shown to significantly increase after 4 centimeters. Based on these studies, and that's why 4 centimeter and above is said to be the definition of the aneurysm. So if you have 4 centimeter, if your aorta is 4 centimeter and larger, your risk abruptly increases compared to less than 4 centimeters. Another study. This is an experimental study done at Yale. Based on the measurement during the surgery, wall stress of the aorta for each patient was calculated. So in the gray, you see the wall stress with a blood pressure of 200. We are seeing dark gray, the wall stress at 100. As you see, the larger the aneurysm is, the higher the wall stress is. And it's notable to see the correlation between the wall stress and the blood pressure. So not only the size of the aorta, but also the blood pressure matters in reducing the wall stress of your aorta. But again, this also highlights the importance of the size in managing the risk, in talking about the risk of an aortic aneurysm. I show this graph to all of my patients. The chart on the right is based on over 3,000 patients who are managed at Yale. Now, at Yale, they have a historical database where they manage patients without surgery. Horizontal axis is the aneurysm size, and the vertical axis is the annual risk, annual risk of aortic events, including rupture, aortic dissection, and sudden death. As you see, Based on this, 5 centimeter is our cutoff for surgery because 5 centimeter is just below this first hinge point. Another important caveat is adjusting the aneurysm size with body size of the patient. Everybody has different stature and height. Data suggests the risk is best adjusted by height, not by BSA or weight. This metric is extreme and particularly useful when seeing patients who are very short, typically old female patients. With this knowledge, let us go back to the guideline chart. I simplified the wording. If you are symptomatic, surgery. If you have no symptoms, we look at the size. Over 5.5 centimeters, surgery. Between 5 and 5.5, surgery is recommended. But certainly, it depends on the patient's risk factors and other factors like family history and for very tall or short patients, adjust for the height. But at the same time, the chart also still has some uncertainties and unfamiliar wordings. It says sporadic aneurysm, and also it says MAT. What are they? In fact, if you know before understanding those wording, the guideline remains quite complicated, and it has to be. The chart we reviewed covers only the left-sided path. For others, we need to know family history, genetic syndrome, and genetic testing. Again, the far left is quote-unquote sporadic aneurysms. So if you have an aneurysm just by yourself, with no other family factors, genetic factors, we follow that chart. But otherwise, you have to go into further details. This makes sense, actually, since the aortic risk simply cannot be assessed merely based on the size. Even for the same aortic size, what the pipe is made of matters a lot. The dilated pipe on the right picture will never rupture. So you can imagine how important it is to try to understand the texture of how your aortic wall is made of. One of our chief residents put together this summary table. This helps me understand the complex algorithm suggested by the guidelines. Again, for us, 5 is the cutoff. We look into family history and genetics for young patients and tailor the cutoffs based on those information. For high-risk patients, wait until 5.5. So what about this word MAT? This is important. MAT stands for multidisciplinary aortic team. And this is the concept that was introduced into this new guideline. Just like heart team, surgical experience is important. And this is related to one of today's main themes, second opinion and the experience of the surgeon's expertise. One of our faculty, Dr. Anna Gierson, robotic mitral surgeon, examined the relationship between the annual center volume and mortality rate. The blue bar is the predicted risk of mortality, and the red is the actual mortality. And the gray bar is the actual versus predicted ratio. So looking at the gray bar, the lower the bar is, the better. The lower the bar is, the better. As you see, the higher the center volume is. So the more rightward you go, the lower the gray bar becomes, meaning the higher center volume does a surgery with a better outcome. Note that centers performing more than 50 cases per year are performing the best. Having said that, recently we published this paper. We looked at a national cardiac and aortic surgery database called STS database. Of note, there are only 11 centers in the US that performed more than 50 cases. Again, previous chart showed if you perform more than 50, the outcome is the best. But there are only 11 of them in the US. This data suggests that experience matters, but also that experience is not easy to find. By the way, multidisciplinary aortic team, MAT, it is not only about surgery. Aortic imaging is another very, very important nouns and factor in managing patients with aortic aneurysm. Too often we see patients whose images are misread, or who are totally confused due to multiple different measurements. Recently, I saw an emergent consult for rapidly enlarging aneurysm. The ascending aorta increased from 4.7 to 5.3 in 1 year. Now you understand 5 is the cutoff, and 5.25 is the first hinge point. In that regard, jump of the size from 4.7 to 5.3 is a big deal. Fortunately, it was a measurement error. The patient did not need emergent surgery. So to do a better job in doing better, more accurate measurements, aortic experts use a special software to create this kind of 3D view of the aortic diameter, to measure the aortic diameter. This is particularly important for the aortic root or for any segment of the aorta for aortic dissection, because aorta is not necessarily in circular shape. More important, there are clinically important differences among various images. For root and ascending, we obtain EKG-gated CT angiogram for surgical planning. But that being said, for surveillance or post-op follow-up, other modalities have advantages, like MRI or echocardiogram. So you do have to consult experts to be able to get an appropriate imaging for your status. Furthermore, I believe we will soon see more introduction of blood flow analysis, and that's very important, talking about shear stress, risk of aortic dissections, and that can be measured with the newer imaging such as 4D flow MRI. And overall, the imaging is complicated. We work very closely with what we call aortic radiologists in our aortic center. Shared decision making. This is another key factor that we should discuss today. It is now clearly stated in the guidelines. That is easy to say or put down in the guidelines, but I do not think it is easy for patients. In other words, it's easy to say that we should let patients decide, but that's not easy for our patients. We just discussed how the key parameters like aortic diameter can be misread. There are many other important and potentially confusing nouns in decision making. And for patients to understand all of that and participate in critical decision making is extremely complicated. So for us in our aortic center clinic, aortic surgeons and dedicated nurse practitioners like Annie Yu spend a lot of time with the patient and family to discuss these important details. For this topic, I borrowed slides from our nurse practitioner, Annie. So certainly, Annie can present if she wants, but I'm happy to talk for you as well. But Annie, do you want to say something? I'm sure you remember these slides.
I do remember, but I definitely did.
Okay, if you didn't prepare for this, I can just read through, because I'm going to just read through this.
Yeah.
But these are very, I think, useful for our patients. So Annie prepared 3 typical scenarios that really she spent time discussing with patients. The first patient, 39-year-old female with Marfan syndrome and 4.4 centimeter ascending aortic aneurysm, enjoying going to the gym. Can she continue doing exercise regularly? Second patient, 28-year-old male with a 4.9 centimeter aortic root who works in construction. Can he keep working? So construction, the heavy lifting. 55-year-old female public bus driver with a 5 centimeter descending aortic aneurysm. Can she keep working? Can she drive her students or other people for her work? These are complicated situations. So exercise recommendations. Again, I'm just reading what Annie wrote. We encourage moderate aerobic exercise unless they need surgery. Then we do surgery. So people who are being under surveillance program, this is what we do. We encourage moderate aerobic exercise, walking, jogging, swimming is good, cycling is good. We also ask them to refrain from isometric exercise. So many of you heard heavy lifting is not good. Planking for a long period of time, pull-up holds. Refrain from high impact and competitive sports, rugby, football, hockey, racing. There are many in-between situations like skiing, blah, blah, blah. Annie, do you want to add anything else?
So I typically, yeah. So, in addition to all of this, it's really, for me, a lot of it is really about the breathing, right? A lot of my patients will ask about, well, what if I do this one thing or that one thing, roller coasters or this or that? And I always say, everyone's different, everyone's physical capacity is different, but it really is about the breathing. If you feel like you are holding your breath or grunting or bearing down to do an activity, or if you feel like it's an activity that's going to cause your blood pressure to go really high, then I say scale back on that. But if it's something that you can do easily, if you can breathe through it, if you can really just, breathe and relax and exhale through it, then it's typically okay.
Mm-hmm. And in that regard, these recreational activities are definitely fine, right?
Mm-hmm. Yep, that's
That
correct. All
includes
of those.
driving, travel, sexual activities, swimming, snorkeling, diving, occupational. What are you going to say? Anything?
No, for occupational, it really is,
Right.
we had a handful of people who work in construction,
Mhm.
who really don't have an option in terms of not lifting very heavy things and not grunting. And then, we make it's a very detailed conversation about for that individual's risk. We'll say, if you're 4.9 or just at 5, just under 5, we might consider doing surgery just a little bit sooner for someone who really has no option but to continue doing very physical or very strenuous isometric activity. But that's, at our center, we really tailor everybody's plan to the individual.
Perfect. So going back to our patients, the first patient, our answer was yes, keep in mind our weight bearing guidelines. Careful planning will be needed for pregnancy. Second, for the second patient, surgery will be recommended very soon. And like Annie said, for construction workers, no, they have to keep working for for their living, and we do operate in relatively more proactively than others. 50, no, the last scenario is a tough one. No, we cannot write a letter of clearance per se, so it's a tough one. Anyhow, but this is the actual real life scenarios where particularly Annie, no, we do struggle with you, with the patients. Okay, so living with an aortic aneurysm, aortic condition means a lifelong care. You can think of surgery as a milestone, but not the finish line. Just as we monitor your aneurysm closely before an operation, like Annie does, and we talk about it, how living style and so forth, we follow the same vigilance afterwards. The table on the left shows the guideline recommended follow-up schedule after aortic surgery. The table on the right is ours. Ours is more intense. In both cases, structured ongoing surveillance is essential to your long-term health. We actually audited our program's results to see how follow-up impacts outcomes. The chart on the left tracks the percentage of our patients who received at least one imaging study after their aortic operation. It was sad to see that we failed to follow over half of our own patients, despite our frequent reminders they have to come back. On the right, though, no, it is outstanding to see survival curves. The patients who had follow-up imaging, blue line, enjoyed significantly better long-term survival than those who did not come back. In other words, follow-up isn't just for recommended. It is truly saving lives. We define surgical success by key goals, like I said at the beginning. First, preventing any aortic event. And second, restoring you to your normal life as smooth as possible. We refer this smooth return to normal life as an uneventful recovery. So we track that metric in our program and we pay a lot of attention because at this point, aneurysm repair, I'm not talking about aortic dissection repair, which is tough, but aneurysm repair for us, mortality has become not an issue. No, rarely anybody dies from elective surgery anymore. However, we also want to pay attention to preventing any kind of complication. That's what we say uneventful recovery. Currently, we are more and more patients are experiencing uneventful recovery. It used to be around 60%. Now over 90% of our patients experience recovery with no hiccup whatsoever. Let's review aortic anatomy a little bit, switching the gear. The most straightforward procedure is an ascending aortic replacement. And I hope many of you are familiar with an anatomy picture like this. With ascending aortic replacement, we simply replace the ascending aorta, this mid segment of the aorta. When we extend the repair to include ascending aorta and the aortic root, then what we call an eventful recovery, or flip side of an eventful recovery is eventful recovery, or percentage of the patient who experience some kind of complications. That increases from 11% to 16% by extending our repair to more proximal. What's notable is if we extend the repair to distal toward the arch, that number goes up significantly. In other words, no simple operation, you have good recovery. The aortic root operation is relatively straightforward. No complication is rare. But if we extend that toward the arch, we start to see more complications. But by the way, none of these patients are really dying. We are talking about other complications, particularly the duration of being on ventilator, that becomes longer. Nonetheless, the more operation, the more the complication that you experience, highlighting the need of paying attention to the expertise, seeking for expertise, especially if you need complicated aortic surgery. Finally, I would like to discuss 3 key aortic surgical procedures, again, to reiterate the need of expertise in those 3 operations. First is aortic root surgery, which we perform when an aneurysm involves the aortic root. A critical goal of this operation is, whenever possible, to preserve your native aortic valve. If it's not possible, we must implant a prosthetic valve, which carries some long-term limitations. But for this reason, aortic root surgery is best done by teams with a specialized expertise in what's called the David procedure, or aortic valve sparing aneurysm repair. And this is the actual picture of the aortic valve sparing aneurysm repair, or the David procedure. In this chart, the horizontal axis is the time since surgery, and the vertical axis is the probability of survival. Notice how the green line, that's the patient who had aortic valve sparing aneurysm repair, rises above the other patients. The other patients had prosthetic valve, whether it's a mechanical valve or bioprosthesis or tissue valve. This indicates that patients who keep their own valve tend to have better survival. So again, pointing out to the importance of seeking for expertise. I'm going to skip this surgical valve because some of you may get nauseated. The second procedure that I want to mention is the aortic arch operation. So like I mentioned in the previous slide, the more extensive surgery you have, the more likely you develop some complications. Aortic arch surgery is more extensive than any other surgery that we do. This data shows data from the national database. As you see, mortality, the chance of dying from this operation in the national database is 6.5%, which is not trivial at all. It's a it's a serious operation. If you combine mortality and permanent stroke, the percentage goes up to 10.9%. Therefore, we tailor this operation, and we could do that. And then that operation is called zone 2 arch replacement. And Dr. Patel here, again, he is the chief of our vascular surgery, and myself does this operation together. We can do that because we work together. Instead of replacing the entire aortic arch all at once, we do partial replacement of it. Then we stage the repair. Later on, we come back with a stent graft, which is an endovascular catheter-based procedure, and we repair the aneurysm that way. And when we do this in recent series, when we look at the progress of a management with zone 2 replacement, so this Z2R, recently operative mortality is as low as 1.4%. In fact, only one patient passed away after this operation, after 2017. By the way, 2017 is when myself and Dr. Patel started to work together. Finally, I would like to introduce total endovascular arch repair. This is actually the super expertise of Dr. Patel. And I don't think Dr. Patel, I think he's now driving. I hope he could talk about this, but maybe he can make a comment later on about this. This is an entirely catheter-based technique to repair the aortic arch. Hey, V. So I'm gonna give grand talk and then you can chime in maybe. So here in this slide, I'm showcasing the what's being developed. In addition to the highly skilled vascular surgeons, industries partners are developing these devices to do this operation without open surgery. And Dr. Patel has done many of these in our institution, and for him, he creates the own graft, so to tailoring the graft to each patient's anatomy and repairing these aneurysms without open surgery. I don't want to go into the detail of these procedures, but this is one of the cases, one of such cases where we repaired an aneurysm without opening the chest at all. These patients do extremely well. Okay, so finally, let's go back to this slide. Do we usually operate at 5.5 centimeters or now 5 centimeters because of the new guidelines? We always want to remind two goals: to prevent aortic events and bring back to normal life. And for that, we have to look at several things. First, anatomy. We study anatomy very in detail, like Dr. Patel, Annie, myself, and we have two other additional surgeons and one additional nurse practitioners. 6 of us get together and we look at the anatomy closely with our radiologists. And then we individualize the type of the care that each patient needs. We also look into the integrity of the aortic wall by doing genetic testing. We look at the previous pathology slides if patient had an aortic repair in the past. And we, of course, assess the risk of the surgery, but we want at the end is a happy patient, not only the happy aorta. So we want to make sure our patient can tolerate the surgical planning, the surgical strategy that we identified. And finally, and not least, now we take care of the patient's non-medical factors into consideration. what kind of lifestyle they want to have, how they see how they want to manage their health, and we decide we answer this question with the patient. With that, I would like to open our conversation to the questions. Thank you very much, everybody, for listening, and thank you very much again for the foundation for this opportunity.
Thank you, Dr. Takayama. I think before we jump in, do any of the other presenters would you like to add anything or any comments?
Vicky, do you have any comments about our arch work or your endo work?
I mean, thanks. That was a great talk, Hiro. In terms of the arch work, we don't really have devices commercially available. There's a single arch branch device that's been commercially available, but applying that to normal, healthy patients is probably not ideal. Additionally, there are 2 branch grafts that are going to be coming into trial, or one that's already been in trial. But the problem with the arch is there's so many important blood vessels that that emanate from the arch that dealing with the aortic arch and all of the branches in an endovascular fashion is very high risk in terms of stroke, which the international experience is kind of borne out. What we know is that the trial, or the device that's in trial in the United States at the moment, was associated with very high risks of stroke. That being said, it's usually aneurysm patients that have debris in their arch that are the highest risk of stroke, whereas patients with chronic dissections and arch aneurysms related to chronic dissection do very, very well. What we have done is, as you pointed out, is off-label surgeon-modified grafts. We've treated probably 10 or more, actually probably more than 10 at this point, total arch endovascular cases. We're highly selective because we're so good as an open center that patients really have to meet high risk criteria for us to say we're not going to offer a conventional operation, and we're going to do this really off-label procedure. Because of our careful patient selection, our outcomes have been very, very good. We've only had 1 patient with a sort of a minor stroke that they're fully recovered from, as opposed to literature which suggests that, up to 20% of patients can have a really bad outcome. So I think the team approach, I think the quality of our team, I think the quality of our institution, and the people that support the patients intraoperatively and perioperatively is really what drives our outcomes. But hopefully we'll have better and more advanced devices in the next 5 to 10 years.
Yeah, thank you. We have a couple of questions that branch off of what you just discussed. The first is, what is the protocol for an aortic root aneurysm? Elective surgery, is endovascular possible, or is it always open heart?
For the aortic root, no, for now it is an open procedure. There is innovative procedures that have been described from the world. The first one came from Brazil. It's called endobentol, where aortic valve, coronary arteries, and the aortic root all reconstructed through endovascular ways. But that's far, far down the horizon. So, like Dr. Patel said, we are very aggressive in introducing technologies and advancing endovascular procedures. And by the way, Dr. Patel does many other endo procedures for thoracoabdominal aneurysms, complex AAAs, open and endo both. So with that knowledge, background knowledge, yes, aortic root remain to be an open surgery for a foreseeable future. For selected high-risk patients, like say 90-year-old with a type A dissection, or who just cannot tolerate surgery, again, Dr. Patel and we have been doing ascending aortic endovascular work. So it's on the horizon, but it's not in the mainstream yet. That being said, the good news is it's an open surgery, but aortic root surgery the outcome is fantastic.
And a question, any thoughts on the Paris procedure? Can you explain what the Paris procedure is and will it come to the US?
Yeah, Pierre's procedure is essentially a wrapping of the procedure of your aorta. So there is a net, sort of, if you want to picture it, which we can use to wrap the aortic root and the aorta. The idea here is the net will get incorporated into the aortic wall over time, strengthening the integrity of the aorta, thus preventing aortic rupture or aortic dissection. That operation is not a device or net is not available in the US. That I got that question asked many times by Marfan patients because the person who developed that net is actually I believe has a Marfan syndrome, and it's being utilized in the UK and Europe. There is some promising clinical data coming out. It is not in the mainstream in the Europe yet, and again, it's not available in the US yet. So remain to be seen.
Thank you. How does a bicuspid, oh, did you have
I have a question. I have a comment. So, for as long as aneurysms have been known, there have been multiple things that people have tried to repair them. In the early days, people would stick a needle through someone's back and fill up the entire aneurysm with wire to try to get it to stop flowing. They ruptured anyway. Then people tried to tie off both ends of the aneurysm. And this is specifically to abdominal aortic aneurysms. And then patients developed leg ischemia. Then people actually developed these wrapping modalities to try to protect the aneurysm from growing or rupturing from the outside. The most famous person who died of an aneurysm after their aneurysm was wrapped was Albert Einstein. So wraps and all of these sort of other types of less invasive techniques have been tried in different other sort of anatomic locations. I'm not sure that it's actually going to work for the root or the ascending either. What it will do is it'll create much more scar tissue for when you actually need the real operation. So the jury's out on the ascending, but I can tell you that nowhere else in your aorta should you ever have a wrap.
Mm-hmm.
I was going to ask about bicuspid aortic valve, but I'll do that one next because we have a few questions that were submitted and are being asked right now. You mentioned going to centers that do this regularly. Usually when people reach out to the John Ritter Foundation, we share the Marfan Foundation Institution Directory. Do you have any other ways that patients can find centers that routinely do these kinds of procedures? How can they go about finding them?
Well, they can reach out to us and then we can give them recommendations. But I think that's why John Ritter Foundation, Marfan Foundation, National Marfan Foundation, those patient-centered entities are very helpful. And of course, if you go to website, every single hospital says that we are excellent. So I would suggest to the patients to go talk to your cardiologist, and they usually have connections, and then see the surgeons or aortic team that your cardiologist would recommend. Then after that, do one more. Go for a second opinion. But typically, we work in New York. In New York, pretty much everybody sees 2, 3, sometimes 4 surgical teams. Typically what I found was by the time you see the first surgical team, you get to learn about your disease, and also you get to learn about the background. You get more insights about this problem, your problem. And that's one of the knowledge you gain is which center has more experience in this. So again, trust your cardiologist and then go see your first surgical team and seek for a second opinion. And in addition to reaching out to foundations, that would be my advice.
Thank you. And I just shared the link to the Marfan Clinic Institution Directory, which consists of the multidisciplinary centers. It's not an all-inclusive list, so there might be clinics and centers that are not on the list, but you could always reach out to the John Ritter Foundation, and like Dr. Takayama said, to your cardiologist, and we can all work together and help you get, to a center that is helpful for you. Okay, and how does a bicuspid aortic valve impact decision-making when it comes to surgery?
Yeah, a great question. So bicuspid aortic valve is known to be associated with two things: ascending aortic aneurysm and aortic valve disease. And both are relevant. And typically, most commonly, the patients ended up needing some type of procedures with a valve surgery or TAVR because of the valve. And occasionally, patients also has aneurysm, and patient needs an aneurysm repair. It is unusual, but every now and then we see patients whose problem is predominantly aneurysm. Typically, cut line, the threshold to recommend surgery in bicuspid patients are now the same as patient with a regular anatomy, tricuspid aortic valve or trileaflet aortic valve. So 5 centimeters is the cutoff for them. But if you are needing surgery for the valve, we lower that to 4.5 centimeters. Good question.
And to go on that, build off that, do any genes impact that?
Yeah, for bicuspids, there is no single responsible gene has been identified. It's being considered to be the many genes being involved in the process. And there are a few key genes that seems to be related, but again, there is no single responsible gene. Still, though, we recommend genetic testing for two reasons. One, you may have some overlapping genetic conditions, and two, your genetic testing now will help in the future if we discover new genes and so forth. And bicuspid patients, they present in younger age than tricuspid patients, whether it's for aneurysm or for the valve disease.
Thank you. This one is a specific case from a person. The past 3 years, a CT scan has shown the aortic arch diameter being between 6 and 6.2 centimeters. They had a previous open heart surgery 12 years ago. There's also another aneurysm in the abdominal aorta measuring 5.2. Surgery is still being decided and debated. They're 56 years old. How dangerous is it to have two aneurysms of those sizes, and to continue monitoring it versus not having surgery?
I think that's a perfect question for Dr. Patel. I don't know, V seems to be working in the hospital. V, did you hear the question?
Yeah, so sorry, I'm in a hallway. There's an echo. I apologize. In terms of the 6 centimeter arch aneurysm, obviously arch disease is complex. It sounds like the patient is young. If they have connective tissue disorder, in our center, we probably would have offered repair for a 6 centimeter aortic arch. If there's been rapid growth, we would offer. If the prior surgeries were extensive and there's a lot of scar tissue, I can understand not wanting to have surgery. So there are a lot of patient-specific factors that need to go into decision-making in terms of the arch. Is there mural debris? Can it be fixed endovascularly if an open operation is not possible? But in a 56-year-old, I think we would generally recommend open repair, whether that be a total arch with a frozen elephant trunk or conventional elephant trunk in a patient with Marfan's or connective tissue disorder, or a zone 2 followed by a TVAR. But again, we have every option at our disposal. So that's what I would suggest in terms of the arch. As far as the abdominal 5.2, if it's a straightforward infrarenal 5.2, the general consensus is to repair at 5.5. However, if there's been rapid growth or the patient has connective tissue disorder, or if there's associated chronic or acute dissection, then that should be fixed at a smaller size.
Thank you. And this one is kind of pulled from multiple questions as well. You mentioned that, once you have your surgery, it's lifelong. It's not the fix for it all. What exactly should be looked for and why the need for continued monitoring?
But if, Annie, do you want to take on that?
Sure. Yeah. So, the way I explain it to my patients is that, we always want to make sure things look good after surgery. We're not expecting to find anything wrong, but rarely we can find little, what we call pseudoaneurysms at the suture line. Again, that's very rare. But I always say we just want to make sure everything is looking good. Sometimes, and that's actually for aneurysm surgery. If it's a dissection patient, that's different. A dissection is a bit of a different pathology, and we want to monitor those patients a bit more carefully because there's still disease. Once you dissect, there's the entire aorta that's been dissected has some weakening, and so we want to watch for areas of aneurysmal degeneration or other aneurysms developing down the line. And so we do tailor our protocol to patients who have had surgery for single aneurysms versus patients who've had surgery for aneurysms with dissection. And so everyone has slightly different protocol that comes through our center depending on their pathology and their history.
Thank you. Is there a database that covers dissections per year compared to those who dissect under watchful waiting? They're wondering if the risk for dissection is less compared to people who actually aren't being monitored.
Yeah, that's actually a very good question. And there is no database of that kind, of multi-center database of that kind. But certainly we have our own database, and it is very, very rare for patients to develop aortic event under our watch. Because typically what happens is either a patient continue for surveillance or we electively repair the aneurysm. But that said, we have seen it. We have seen everything. There are unusual scenarios where the patients develop an aortic event, and suddenly, they call us, and then we immediately guide them what to do. Some of them just come right back to us and we operate. Some of them were traveling. We refer them to somebody who we know, and so forth. But no, those are extremely, extremely unusual. Annie, would you agree with that?
Yeah, I agree with that.
Yeah.
And going back to the topic of finding a center that does this routinely, how can people find out how many aortic surgeries a center has done? Or like you said, you guys have your own database. How do you recommend people find out this information if they're researching where they want to go for surgery or to be monitored?
Mm-hmm. This is a tough, no, because there is way to learn the center volume, but it's not in easily accessible public domain. Again, I think from patient's perspective, looking for a second opinion matters. No, I think that way you will learn. Your cardiologist will also learn or try to study for you. And when you meet with the surgical team, when you meet with a surgeon, ask how many he or she has done. Just directly ask. I think that is very good. But there is no straight, no, I wish there's a table showing the volume of each center.
I will say that the clinic in directory from the Marfan Foundation also has, if you click on the clinics that are clickable, the clinics each fill out the volume and surgeries that they've performed. I'm not sure how updated it is. I think it last updated last year or 2 years ago, but uh, it's also depends on if the clinic submits that information to them. But that's another way that you can look into that. We are
Can I
at,
do one more thing?
yeah,
I think the other thing, Hero showed is that he showed some of our own literature, results of our own experience. And so centers that are usually high volume will be publishing their work. And you can easily Google your surgeon online and find out how many publications they have and how many publications are related to your disease process, right? So if you Google somebody and they've done 5 million varicose vein procedures, they're not really an aortic surgeon. Or they published a lot of papers on varicose vein repairs. They're not really an aortic surgeon. So just keep that in mind that, we as clinicians who are interested in specific topics do clinical outcomes research, one, to understand what our outcomes are, two, to try to improve our outcomes, and three, clinical outcomes research is basically advertisement that says, we do a lot of this, we're good at it, we have figured out what goes wrong and what doesn't go wrong. And so clinical papers actually is, in the academic world, our own self-advertisement of our experience.
yes, that's a very great point.
And I do want to add, I don't know if this was touched on earlier, Hero. I did have to step out for a minute. I guess to touch on getting a second opinion, and a lot of centers will offer telehealth visits. That's something that we do. We are able to see patients from out of state, depending on licensure. But and we do have patients sort of do a virtual consultation with us. We'll look over the records and we'll give our opinion. And we have had patients, travel from other states to see us and to have surgery with us. I know that's not necessarily accessible for everybody, but it is an option. At least that sort of virtual consultation is available at many centers.
And I know we have someone from Malaysia on the call as well. We do see patients from internationally as well, so we can help facilitate getting those appointments down as well. So if there's interest from other spaces, I know that patient had asked a question earlier as well, so just wanted to make sure that that information is out there. So you can always call our teams and we'll get you scheduled too.
Thank you. That's so awesome. So we are a little bit past the hour. There's a couple more questions. Do you have time to answer them, or could we have them follow up with us and get an answer back to them?
Yeah, sorry, I have to hop out, but I don't know if the rest of the team can stay. And also, again, no, I really enjoyed joining here, and I know your foundation is fantastic, and Dr. Patel and Annie has been deeply involved in on the Galan and so forth. So, and in that sense, I think we are happy to come back as well. But I do have to hop out. Sorry.
Thank
I
you.
can take a stab at a couple of the questions.
Okay. Thank
Thanks,
you for
Dr.
coming.
Takayama. So, in terms of the descending thoracic aortic aneurysm, someone says, I had a open heart surgery for ascending, now being managed for a descending. Will this be discussed in the future? I think this would be a great topic for us to discuss in the future. Maybe Dr. Patel would be willing to do a talk on that, because we see this a lot, and so definitely. Thoughts on Mayo Clinic Phoenix as a surgical center? I'm not sure. I'm not super familiar. I
I
don't.
believe on the Marfan Clinic list.
Okay. I feel that anyone on that list is probably quite good. Being followed for 4.1 centimeter ascending, no plaque. So yeah, I think as long as they are on the Marfan Center list and they're following you pretty regularly, 4.1 is for most people a small aneurysm, so keep being followed there. Ross procedure in younger population, that is something that Dr. Takayama does do often. I don't want to get too much into surgical details without him, but it is something we do very often here at our center. How many surgeries would be considered very experienced? How do you measure that per year, per career? Dr. Patel, do you have any thoughts on that?
So in terms of career, I think, there are fluctuations, some years are busy, some years aren't. I think again, as we talked about in terms of the experience, you have to meet your team. You have to get a sense of whether they actually know what they're talking about. Where have they published? What is their reputation? Um, I don't think there's any distinguishing features from a very high volume place to an extremely high volume place. I don't, as Hiro pointed out, there's 11 centers that do 50 cases a year. So it's really just a matter of, is this team experienced in managing aortic problems? And, you know, their local reputation, your cardiologist's understanding of the program will kind of help you sort of decide on that factor. I don't think there's any, well, who does the most in the country? I don't know. But in terms of that kind of stuff, if you're all you're doing is or there are problems at the extremes of volume, right? So why is one center doing way too many compared to everyone else? Are they just fixing everyone that walks through the door? I think the key is you have to meet the team and decide whether you feel comfortable with them taking care of you.
All right, thank you. Are there any final comments from you or your team? This was a great webinar.
No, I mean, we have a great team. So we all love what we do. We love taking care of these complex patients. And we hope to continue to do that for a very long time to come. Thank you very much for having us.
Thank you. Thank you all for your time.
Thank you for having us.
Thank you.
And for all of y'all who are on still, I'm sharing the link to the John Ritter Foundation support page. So if you have further questions on what we talked about today, we can do our best to answer them, help connect you with the team if you would like to go, see them at their clinic. And we also have resources to help you navigate a new diagnosis of an aneurysm or a dissection for you and your family. This is a recorded webinar, so it will be available on our YouTube page, and everybody who attended and registered will also get the recording sent to their email once it's available. So thank you all for joining us, and I hope you have a great evening.
Thank you.